Good afternoon, everybody. I am Jill O'Brien, Senior Health Policy Analyst at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Welcome to this afternoon's webinar about confronting the mental health effects of COVID-19 in America. The Alliance for Health Policy gratefully acknowledges the Commonwealth Fund for supporting today's webinar. You can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We want you all to be active participants, so please get your questions ready. Here's how you do it. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time and notify us about any technical problems you may be experiencing. Check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available there soon. Now, I am so pleased to introduce Reggie Williams to moderate today's discussion. Reggie is Vice President of International Health Policy and Practice Innovations at the Commonwealth Fund. He also serves on the board of Mental Health America, a nonprofit dedicated to helping people live mentally healthier lives. Reggie, thank you so much for joining us. Now I'll turn it over to you to introduce our panelists.
Thank you, Jill. It's no secret that at a time when the countries around the world are reopening and ours is still struggling to return to work and daily life, as the number of confirmed COVID cases and deaths in the US continues to climb, we need to start implementing public health measures that we know work, like mask wearing, social distancing, robust testing and tracing to help stop the spread of COVID-19, as so many others around the world have effectively accomplished. We have an opportunity to look abroad for innovative solutions. There are valuable lessons we can learn, particularly improving access to mental health services and addressing the social and economic needs of people that have been exacerbated by this pandemic. Mental health and solutions to improve mental wellness are the focus of today's webinar. Today, I'm so pleased to be joined by an esteemed group of experts. First, we have Paul Gianfrido, who is the President and CEO of Mental Health America. Previously, he served a 4-year term on the National Advisory Council to the SAMHSA Center for Mental Health Services. Earlier in his career, he served in the Connecticut House of Representatives and was the mayor of Middletown, Connecticut. Next, I'm pleased to introduce Beth McGinty, who is an associate professor and the associate chair for research and practice in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. She is also the deputy director of the Center for Mental Health and Addiction Policy Research and associate director of the ALACRITY Center for Health, Longevity, and Mental Health. And finally, I'm pleased to introduce Kevin Martone. Kevin is the executive director of the Technical Assistance Collaborative. Prior to joining TAC, he was the president of the National Association of State Mental Health Program Directors and served as the deputy commissioner of the New Jersey Department of Human Services. So excited to have this wonderful panel of experts here today. But before we get started with the panel, I just wanted to mention a few opening comments. We at the Commonwealth Fund released a report last week. Do Americans face greater mental health and economic consequences from COVID-19? Comparing the US with other high-income countries. It's the latest of the fund's cross-national healthcare comparisons. It provides country-specific data on people's experiences during the early months of COVID-19 from March to May in the United States, Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, and the United Kingdom. From our research, it's clear that mental health and economic impacts of the COVID-19 pandemic are taking a substantial toll on people across the globe. Data from our research demonstrates that US adults, when compared to people in other high-income countries, face greater mental health and financial consequences from the COVID-19 pandemic. We found that 33% of people in the US report experiencing stress, anxiety, and great sadness that was difficult to cope with alone since the outbreak started. This was followed by the UK and Canada at 26%. Also alarming, we found that less than a third of the people in the United States who wanted to get care were able to get mental health care, with a similar rate in the UK. But people in Canada and Australia were better able to access the care they wanted. The survey findings clearly demonstrate that people in the United States face greater mental health and economic challenges from COVID-19, have relatively low levels of trust in their national leadership compared to residents in other high-income countries. As the number of confirmed COVID-19 cases and deaths in the US continues to swell, national, state, and local policymakers can look abroad to early lessons learned and innovative strategies for dealing with the coronavirus. Today, in our discussion, we'll be able to speak and hear from experts that are focused on US policy and how we can make some changes in our country. Thank you. And now I'm going to turn it over to Paul to make his opening remarks.
Thank you, Reggie. I really appreciate the opportunity to be part of this, and also just to thank you for the information that you shared to start this off. I know we're going to be talking, the three of us, and throughout this hour about the levers and policy levers that people may be able to use to address some of what we're seeing. But at Mental Health America, we are seeing a lot of what you've seen in your report. We have an online screening program that about 750,000 people have used over the course of the last 3 months. And they are telling us the very same things that in real time that your study has demonstrated. So I think people need to pay attention to the information that you've provided and to think about the policy opportunities that can present themselves at the federal, state, and local level to address some of this. Now, one of the first things that I, of course, at Mental Health America will talk about is the need for widespread screening for mental health. As much as we think we should be doing testing for COVID-19, at the same time, we ought to be doing screening for mental health issues. Since the start of the pandemic alone, about 90,000 people who have taken a mental health screen at our website have told us that they have suicidal or self-harm thinking on more than half the days of the week. And when we are seeing problems that are that big across the nation, we really need to be thinking about addressing them at the earliest possible time, before stage 4, as I like to say. In addition to promoting widespread screening, as the U.S. Preventive Services Task Force recommends for everybody over the age of 11, we need to recognize that our school kids are particularly at risk. 11 to 17-year-olds are suffering the ill mental health effects of the pandemic more than any other age group in our screening population. And yet this occurs at a time when we have either not fully funded the special education mandates or actually reduced the special education funding for people who are identified with the SED label, which would be the label for children who are experiencing serious mental health problems. From the local level on up to the federal level, we really need to take a look at that as children are returning to school and recognize that there's a greater need than ever before to do more for children through early identification, particularly within schools and school-based populations. And of course, that sort of points out the real issue that is out there in terms of the way we think about mental health issues differently from physical health issues. You know, when the crisis is in physical health, we all rally to do something about it. When the crisis is in mental health, we have a tendency to separate and segregate people from the rest of society and from the healthcare delivery system. A lot of states and the federal government continue to wrestle with these issues of parity, not just through insurance parity and payer parity, but in general, just treating people the same no matter what condition they have. And of course, treating people the same no matter what racial or ethnic group they happen to be part of. And we've been learning that that really hasn't been happening for a good long time. And I think really when we look at more deeply into people in need, I think this is an opportunity also for us to think really strategically about our mental health block grants and our both on the substance use side and on the mental health side. Both sides of Congress at this point have indicated they'd be willing to increase block grant funding on the mental health side by at least $1 billion in the mental health block grant, which would far more than double federal money coming into states for this. I think it's going to be critically important that we leave as much flexibility in that funding as we possibly can, in addition to making certain it actually gets appropriated. So these are opportunities, and in that instance, that really helps at the deeper end, and it helps with all of those organizations that are providing all those services to people, both inside and outside the healthcare delivery system. So we have opportunities. We have opportunities to think about whole people at this point, not just pieces of them, and have opportunities to recognize that not only is COVID-19 taking a huge toll on the mental health of the nation, but that's a toll that has been taken even before the pandemic and will continue afterwards. And we now have some awareness of and opportunities to make a difference here. So thank you for the opportunity to share those thoughts.
Great. Thank you, Paul. Beth, now could we turn to you and hear some from your perspective around particularly what the Medicare program can focus on?
Absolutely. Thanks so much, Reggie, and thanks to the Alliance for Health Policy for the opportunity to join this important conversation today. I recently had the opportunity through work with the Commonwealth Fund to consider gaps and opportunities for improving mental health coverage in Medicare, which is my role on this panel today. Medicare is a program that covers a population with high need for mental health services. About 1 in 4 Medicare beneficiaries overall have a mental illness diagnosis. That prevalence is much higher, however, among Medicare beneficiaries under the age of 65, where about 60% have mental illness. So this is a population where we really need to be thinking, particularly in the context of the COVID pandemic, where, as you've heard from both Reggie and Paul, we are seeing exacerbated needs for mental health services. This Medicare population is one where we really need to be thinking about how to enhance access to services. So I'll highlight 3 places that I think are key opportunities for some policy action in this realm, and we can go from there in terms of the discussion. First, there are psychiatric inpatient day limits in Medicare that place Medicare squarely outside of parity, which we as a society, in my view, should be aiming for. Medicare is now at parity for outpatient mental health visits, which is recent and important progress, but still places a very strict 190-day lifetime limit on mental health inpatient visits. And as you can imagine, that 190-day limit, particularly for Medicare beneficiaries under age 65, can run out very quickly. And that 190-day limit on mental health inpatient days is far more stringent than Medicare's limit on general medical inpatient days. That limit is a 90 days per beneficiary per benefit period, so much more generous. The second area that I want to highlight for potential opportunity for improvement in Medicare is improving Medicare Advantage mental health networks. We have good evidence from multiple studies that we have very narrow networks in terms of mental health providers, and many Medicare Advantage beneficiaries are forced to go out of network to get the care that they need because there are so few mental health providers within their network. And then finally, I think there is an opportunity to improve access to mental health services for Medicare beneficiaries by reimbursing licensed professional counselors. licensed professional counselors deliver a wide range of mental health services, both group and individual services, but they are not currently reimbursable by Medicare. And given that we know we already have a mental health provider shortage that is exacerbated in the context of increased needs due to the COVID-19 pandemic, increasing that group of providers who provide evidence-based mental health services is an important opportunity.
Great. Thank you, Beth, for those opening remarks. Kevin? Hi, Kevin. Just wanted to let you know we're having a little trouble hearing you.
I'm going to start again. There we go. Sorry about that, folks. I just wanted to start with by saying that, we really need to continue to think about mental health as a public health issue, not a public safety issue. Our mental health system is heavily weighted towards the correctional institutional system, and too many people with mental illness had poor to no access to treatment and services prior to the pandemic. And neuropsychiatric disorders are the leading cause of disability in the United States. Suicide is the 10th leading cause of death in the United States. And so, like coronavirus, mental illness and untreated mental illness is really a public health threat, and we really need to see it through that lens. And while we've increasingly understood these things over the past several years and the solutions that go with it, we've made, little progress in these areas, and COVID's really going to exacerbate these problems at the individual and system level in the months and years ahead. Medicaid is the biggest funder of publicly available mental health services, and it does provide a lot of opportunity for states to meet folks' needs. But we also know that Medicaid enrollment grows during economic downturns and disasters, and we're currently experiencing both. During the pandemic, states have used different Medicaid authorities as the framework to make emergency changes in order to maintain critical services. And you may be familiar with these or not. It gets a little bit technical, but these include Section 1135 waivers. They include changes made in Appendix K of 1915C waivers. They include emergency state plan amendments, and they include emergency 1115 waivers. And it's a lot. It's complex. Kaiser actually has a pretty good website and page called the Medicaid Emergency Authority Tracker. And if you take a look at that, actually provides up-to-date information on all the specific state changes that are going on under all of these Medicaid authorities. Most of the emergency changes that we've seen in Medicaid are broader than just mental health, but they do impact mental health services for sure. Few of those changes are specific to mental health services, whereas we have seen many states make some specific changes to other disability groups served through home and community-based services and long-term services and supports, whereas mental health hasn't necessarily had the direct focus. And so that may be something for us to really think forward about in the Medicaid world. In the interest of time, generally, states are responding by making changes within these three authorities in three main buckets. First, they're sustaining or modifying access to services through things like telehealth flexibilities and relaxing provider requirements, such as suspending prior authorizations and location of service delivery. The second thing is states are trying to increase flexibility and reduce costs for service recipients. So that means things like trying to be more flexible with refills for pharmacy and pharmaceuticals. It means waiving copays for individuals. And from the service recipient end, it means allowing increased access to services like telehealth so people can continue to see their care providers. And the third thing is states are making efforts to increase funding to providers to ensure provider availability and viability, frankly. Without the providers, if the providers implode, we have a real problem. And so States are doing things through provider rate enhancements, or even making retainer payments to providers so that they can continue to have that capacity for folks. One of the biggest challenges, despite all of these flexibilities through the emergency Medicaid programs, are just state budget concerns. An accessible, evidence-based mental health system requires a combination of Medicaid and other funding, and we know that. But if states are put in a position to find savings due to the economic crisis, access to Medicaid coverage of services for people with mental illness can significantly be impacted on a negative basis. So emergency Medicaid authorities are good, but only if funding is there to ensure accessible services. And just the final piece on some solutions. In addition to basic treatment services that we fund through the Medicaid program, we can't forget about the social determinants of health. For many folks with mental illness, mental health problems are exacerbated or caused by stressors such as poverty, lack of affordable housing, homelessness, substandard housing conditions, poor nutrition. And Medicaid and managed care have taken an increasing role in the social determinants of health in recent years. And addressing these through Medicaid or other avenues can go a long way in helping people through the crisis and managing Medicaid budgets. Just a quick snippet, we do a report at TAC every couple of years called Priced Out. And it's a glaring statistic, and basically what it is it says that no one on SSI, which is predominantly the population that we're talking about here with serious mental illness folks who are on the Medicaid program, no one on SSI can afford housing, rental housing, at the fair market rent in any housing market in the country, nowhere. And that's a real tragedy, and that has an impact on health and mental health. Other solutions that we need to keep in mind, obviously, are integrated and co-located care. We see a lot of good strategies there. We also need to emphasize the need for outreach type work from things like case management, assertive community treatment, supportive housing. And that means often through a Medicaid lens, we need to continue to find ways to support our workforce to be able to deliver these services, also including the availability of PPE. And the last point I want to make is we also need to ensure that people are not being placed in or getting stuck in institutional settings. This is really a civil rights issue in addition to a public health issue. Discharges and transitions slowed down significantly in many states as workers couldn't go out because they lacked PPE or they were sick themselves. And the original belief that sort of existed was that people would be safer in hospitals or nursing homes. And we know this turned out not to be true and was deadly for many people. And so we need to make sure, that from a Medicaid perspective, as well as other state funding, revenue and resources, that we're trying to provide the right types of services in the right settings for people and really not putting sort of heading in the wrong direction. So I'll pause there and look forward to any questions.
Great. Thank you, Kevin. I want to invite all of the panelists to turn on their cameras and microphones and then really transition into a Q&A discussion. Everyone listening, remember that you can submit questions through the interface at any time as a part of this chat. We're excited to take your questions. To start us off, I have a question. I think all of us here are clear in understanding the impact of COVID-19 on mental health and what some of the impacts can be long-term. What do you think can be done to build an infrastructure to really address the existing and growing need that we're seeing for mental health services? And maybe we'll go in reverse order. So Kevin, I'll let you have that first.
Thanks, Reggie. At a very basic level, I think from a public health approach, we need to think about prevention and early intervention, and our systems rarely have the capacity to follow that approach. We're not built that way. So I think that's important for us to strive as much as we can. I think at a very concrete level, one of the things that's lacking in many parts of our country are good crisis services that could be used as a way to divert people or get people access to services. And when we don't have those in place, people tend to fall into the deeper ends of our system: hospitalization, emergency departments, police systems, and things like that. The challenge then on top of that is, well, when you have a crisis system in place that can divert people, what are they diverting them to if the infrastructure is fragmented? So we really need to think about upstream interventions, access to outpatient services and care, really as the base in our system. But we don't have, and we're missing sorely in our system, those crisis services that can play that critical door. We hope they don't get there. We hope people have access to begin with, but it really needs that as well.
That's
So hopefully I'm not stealing Paul's line here, although I might be a little bit, but I think that it's absolutely critical that we think about scaling up a system for universal screening and effective strategies for referring people to services, which might be clinical treatment or might be other types of services. And we've made some progress on this in recent years. I'll stay in my Medicare lane a bit here in that Medicare has made progress with the annual wellness visit that's reimbursed at a higher rate. Depression screening is one of the preventive services that can be included in that visit. Good progress there, but uptake is very low. And so we really need to be thinking about what kinds of technical assistance and system-wide strategies are needed to implement these types of screenings.
Yeah, and I guess I can jump in there and say, no, actually, Beth, I appreciate saying that, because honestly, I mean, I'm not naive. I was a policymaker 40 years ago, and honestly, we've built this system primarily around the benefits of the provider community writ large. And I mean, and in the mental health systems, the state mental health systems, for example, that was, state hospitals. And we closed down state hospital beds. We just transitioned that to, jails and prisons. And even though a lot of people talk a good game about redirecting funds from these kinds of non-health oriented services, when it comes time to do it, and it's a question of taking money away from your sheriff, or taking money away from the police in order to redirect it here, well, you can kind of see what happens. I mean, we kind of can see over the last 3 months that doesn't go over all that well. But if we really turn it on its head, and everything Kevin said about this, and everything that Beth has said about this is really important, and just said, well, what would we do if we were doing early intervention and early identification? Well, we would start with screening. With cancer, we start with screening. With heart disease, we start with screening, hypertension screening, blood pressure screening, all these kinds of things. Why aren't we just regularly doing the mental health screening that we're supposed to do? And if we took all that information that we got from our mental health screening, then years before we have to deal with crisis services, we actually would be able to direct people into the appropriate medical services, long before the crisis occurred. And that would undoubtedly free up our attention and resources for what Kevin points out is just a critical need, which is getting the right crisis intervention services in place for people when because what they've got is a medical crisis or a health crisis. They don't have a public safety crisis, just as he said. Doing this is a public safety problem, as we have throughout all of our lives, and the generations come before us, was exactly the wrong way to do it. And we know exactly the right way to do it, because it's the way we've done it with heart disease, with cancer, with diabetes, and every other chronic condition.
great. Thank you. Now I'm seeing another question here. It seems as though we know that COVID-19 has had a disproportionate impact on essential workers, including healthcare workers, Black, Indigenous, and people of color. We're seeing special concerns that are raised by pregnant women. So how do we think about the mental health impact with those different vulnerable populations, and one, understanding the impact, and two, meeting them with the types of services that would empower them to improve their mental health? Does anybody want to take that question? All right, Paul, you're up.
Okay, yeah, sure. I figured, I was going to wait and see if Beth wanted to take this one first, just because she hadn't had a first one. But I will do, part of this, because it flows from screening, which should be universal, and some strategies should be universal, and and access should be universal. But the reality is that when it then comes time to plan service delivery, you need to do that with communities in mind. And there are a lot of, as you've mentioned, Reggie, there are a lot of different communities, but unless you go to those communities and plan from their perspective the kind of services you want to deliver, you're going to fall short. And so I think that it's critically important, if we haven't learned anything else over the course, since May 25th, if we haven't learned anything else, we at least should have learned that by now. And so, listening to people and recognizing the kinds of problems, I don't know, things, whatever word people want to use is comfortable, that we built into this system that we need to fix at this point. Doesn't matter where you start. I mean, that's what I try to tell people. You can't just start anywhere, because anything that we would do for initiative would be better than what we're doing now, no matter what somebody's philosophy is or their orientation is. It's like anything would be better than this. So just try something and take a risk, take a chance.
I would just add, we have tremendous workforce challenges in this country, and it's not going to be fixed overnight. But a diverse workforce does not exist in most parts of this country, and that's it's a big issue that we've got to look down the road, to fix, and trying to bring diversity into our workforce. It just doesn't even exist in most parts of the country. The other thing, and it's not to move it away from the mental health treatment and access to services issue, but many of these are, people with mental illness and serious mental illness don't just often have that, right? They experience all these other things that I talked about before, and these structural issues that exist in our systems. And so when we're talking about, trying to improve the overall well-being of someone with mental illness who may be also facing these challenges, we're talking about addressing poverty and housing and transportation and things like that. That will also have a positive impact on their mental health and well-being. But so we have to look at it as, the screening, building off what Paul was talking about, access to services, but we also have to bring in these other social determinants of health that really, I think, can go a long way. And those are often beyond the mental health treatment systems or Medicaid systems capacity and control. But nevertheless, we know that the most successful systems out there are doing coordination and collaboration across systems.
Yeah, I absolutely concur with the points made by both Kevin and Paul. We have well-documented inequitable access to existing mental health services. There's not enough for anybody, but there's even worse access among racial and ethnic minorities and other historically disadvantaged due to structural discrimination and other issues groups. We have to think not just about correcting some of those differences in access to available services, but also, as both other panelists have alluded to, think about building a workforce and a service system that includes culturally competent services. And that, I think, very much needs to be community driven, as Paul alluded.
Great. I know we didn't really touch upon the unique needs of pregnant women, particularly in this time period. Any kind of thoughts about maternal health broadly and what can be done from a services standpoint?
Well, one thing I'll say, I'm certainly not an expert in this area, but when you're talking about prenatal care and women who are pregnant and seeing their physicians, generally, the frontline doctors in this country are seeing mental health issues as well, right? And sometimes they're not equipped, or they don't feel equipped in order to address mental health needs. When they think they're addressing pregnancy, obstetrics, gynecology, or primary care, or whatever it is. And it's especially given the workforce challenges that we have in this country. There are telehealth, teleconsultation types of services that exist out there that can be a resource to professionals like that. So when they're working with individuals who are coming through the door who may have mental health problems, they don't necessarily have to bear the full burden of working with someone, but they can reach out to these consultation types of services to get the support that they need to either work with them or help refer them on to the right types of services.
Yeah. Well, I'm glad you brought up the issue of telehealth, because I think COVID-19 has shown us the broad expansion and the opportunity to utilize telehealth to get people access to services. And so as we see the enhanced access to mental and behavioral health services, utilizing telehealth and virtual care and the like, are there remaining barriers in Medicare and Medicaid or other considerations that we should have around the use of telehealth, virtual care, and other technologies to get people access to services?
I can maybe start on this one, particularly in the Medicare context. So I think the sort of short answer is that we are learning a lot about this very quickly right now. And so from a research perspective, with my researcher hat on, I think some of the answers to the questions you just posed about, are there still barriers? Are there potentially unintended consequences of some of the changes that we've been made yet, which seem largely positive? I think we don't entirely know yet. I think that mental health services are quite well suited in many cases to telemedicine, but there's also research out there that suggests that for some people, face-to-face engagement is really more preferred. And so sort of disentangling that, we have bodies of literature showing that telemental health can also be quite effective for many people. But I think there are patient preferences and unique consumer needs that we haven't sort of totally disentangled yet. On the policy front, we've really seen a remarkable shift in terms of accessibility here with COVID, not only in terms of essentially in the Medicare context, all services that used to be covered for in-person are now covered virtually, with very few exceptions for services that really can't be delivered virtually. And then in addition to that, lifting policy barriers in terms of HIPAA and privacy laws that have made it so people can use technologies that are most convenient for them, including telephone, allowing people to see providers across state lines virtually, getting rid of the originating site requirement, so you don't have to go in and sit at your originating site with the special software. We've lifted all of these barriers very quickly. I think that there's a lot of potential and a lot of interest in studying this moving forward in terms of if we can keep some of these in a post-COVID world, what the potential is for increasing access. I will sort of end on the point that we exist in a world of major mental health provider shortage, and these telemedicine expansions, they sort of help at the margins, right? Where we haven't actually increased the pool of providers. We might increase accessibility at the margins, where if you live in a rural place, now all of a sudden you can talk to a psychiatrist who lives in a city 400 miles away. But it's not going to solve all of our problems in terms of workforce capacity.
Great.
Yeah, I think it'll be really interesting to see how it plays out, right? I think there are a lot of folks that are hoping that there is some sustainability to this post the crisis for individuals. I mean, there's certainly some operational challenges. I mean, when you think about sort of the capacity of the behavioral health providers across the country, you have some very small mom and pop type shops to some very sophisticated behavioral health providers, and for those smaller folks, it may be an uphill battle. There's a lot of training that needs to go along with it. They need infrastructure to be able to support it. And from the consumer or service recipient perspective, there are certain populations where it's very hard. If you're homeless and have a serious mental illness, it's very hard just to maintain access or even have access to, internet coverage, for instance. So there's a lot of operational barriers, but I think there is, the systems have responded pretty rapidly. I think there's probably an interest from what I gather, on the CMS side to see how it plays out over time. And so I think it is a potential, shining light in all of this as we move forward.
And I would just add too that what the perspective that we at Mental Health America understand the best probably is the perspective of the individual who has a mental health challenge. With our screening population, for example, we've had about 5.5 million people come take a screen, and these are help seekers by definition. That's how they find us, because they're seeking help. And only a minority of that population, wants a referral to care or traditional care or treatment. So what people are looking for are also engagement with peers and certified peer specialists, which are used in Medicaid programs throughout the country, but not broadly beyond those, and certainly not with uniform standards at this point that would make private insurers and even Medicare wholly comfortable with them at this stage. Could be a way to augment sort of the face-to-face, person-to-person contact. But when people are also looking for just more information, and they're looking for do-it-yourself kinds of tools because of the nature of mental health conditions, it reminds us that there is likely a demand, an increasing demand for the telehealth services that could be provided, the more of those that are provided. But as Beth says, they're not going to be, or implies at least, if I'm going to put words in her mouth, they're not going to be for everybody. And they're not going to reach everybody, but it is a way to reach an additional, I'd like to say, if there's a quarter of the population that wants information and a quarter of the population that'll do a referral to care, there's a quarter of the population that'll engage with services when they can do it in the comfort of their own home and do it virtually and have some of the boundaries, the personal space boundaries around them that they'd like to have. So it's a way to augment services, but it's not going to replace the face-to-face or person-to-person, and it's not going to solve the provider shortage problem that we have and will continue to have.
So that makes a lot of sense. We have a question here that really focuses on the topic of schools and returning to schools. So given the pressures facing families as children go back to school, and parents struggle with work and to manage children's schedules with or without their usual supports, one would expect that people who need access to mental health services for the first time may be kind of uniquely looking for services as they and their children are kind of going back to school. What tools do we have to help mobilize to meet the needs of families and children during this time?
I don't mind starting on this one just because I brought it up earlier too, and I have a lot to say about this, but I'll try to say just a little bit here in response to the question. We do have tools. We can screen, and we should be screening. And when we suggested that, when we released our July date or June date actually in July, that no school system should be reopening without consideration of meeting the mental health needs of the children and of course the families as well. It gets us a little bit into that whole issue, I think, that you brought up, Reggie, earlier about, perinatal mental health, maternal mental health too. Let's not fall into the trap of blaming the parents for being inadequate to the task of providing for the education of their children as we give them options about whether they're going to be in school or whether we're going to teach them at home. We're asking them to do a lot. So we also have the unique opportunity to rebuild the special education system. Now, a lot of people are afraid of this, right? And for the last 40 years, I mean, really, certainly the last 30 years, we've been cutting back on the number of kids in the special ed system who are identified as a result of the SED label. And what that's meant is that fewer than one child in every 30 right now is being identified. And now if you tack on the additional stressors that children are under and their families are under, I wouldn't be a bit surprised that it's 1 in 40 or 1 in 50 as we're going back to school. So we know what to do. We know that we can develop individualized instructional programs that will benefit for the children and that they're going to need. It's just going to cost us a whole lot of money. But we're spending trillions of dollars in stimulus. So spending tens of billions of dollars right now doing this, and that's what it would cost. I don't think it's too much to ask personally, but it may be too much for a number of public officials. Beyond that, making certain that every child has access. And again, Kevin and Beth have both talked about this today and passionately in the past about this. When you look at social determinants and you look at the stressors and you look at stress-induced, trauma-induced mental health problems so many kids are coming to school with and facing, we need to recognize that and understand it's been concentrated in certain communities and do something about it. And so we have a lot of levers to push here. And it's another one of those examples where I'm not saying everybody's got to do every one of them, but you could do one. You just do one, pick your favorite, and it would make a difference, because right now we're sending those kids in, naked without mental health supports, and we can't be doing that.
Kevin, I guess kind of building on that, that theme that was presented there. As states are experiencing budget shortfalls and increased demand for services, what strategies do you see them employing to meet the increased behavioral health and mental health service needs?
This is the thing that keeps me up at night, and I don't work in state government anymore, but it still keeps me up at night. Despite some of the opportunities that are in place through Medicaid authorities and things like that, the reality is state revenues are hurting. The enhanced FMAP that came in through the CARES Act is helpful, but I think states are still planning for cuts to behavioral health related services in the Medicaid program, for instance. Even though there's some maintenance of effort required through the CARES Act, the reality is states just don't have the revenues, and the potential for cuts there is important. Let me just give you a quick example on that, just to belabor the point. If you have a $10 million program, just start using some round numbers, and 50% of the Medicaid program is funded by the federal government, 50% is funded by the state government, and the state needs to make $1 million cut, okay? Well, that means you're also going to lose $1 million of federal revenue for those programs, which means the states may be making a 10% cut, but it's a 20% cut to the overall program. Significant impact. I think states should really continue to look at their Medicaid emergency authorities and things like that. But it's easy for me to say from the outside right now, because I'm not managing state revenues. But we really need to try to keep those revenues in place for things. The CARES Act came through with other funding through SAMHSA. Arguably, it was a drop in the bucket. Given the level of needs out there. So I think those are important things to consider. At a very basic level, I think coordination is really important between the behavioral health system and the primary care system. Again, some people may neglect or may not have access to behavioral health services, but they may still keep in touch with a primary care provider, or may increase contact with a primary care provider as we sort of come out of quarantine in some states. Those may be opportunities to sort of get that at least basic screening in and try to engage people. But I don't know that I have solutions right now. I am really, really fearful of the economic impact of state budgets. When I look back on the recession, that's when I was in state government, 2009, 2011, the amount of funding that was cut from the public mental health system was very significant. You combine that with, a lot of times Medicaid expansion came in many states, and it expanded access and coverage for many folks. But also what happened at that time was many state revenues went to sort of go into the Medicaid program to be able to cover increased services and coverage. But at the same time, many of the state revenues and the state mental health authorities went away and never came back. So when you sort of look at the declining revenues and you look at sort of just the overall loss of some state revenue dollars directly directed at mental health services in states, you can sort of see, given the economic impact that we're seeing as a result of COVID, that's even going to be worse. It's even going to be compounded as we go forward in the next, not only several months, but a couple of years. I'm really concerned about it.
So, but I thought with expansion states, the feds are picking up like 90% of the cost. And so do you think expansion states are going to be able to weather this time a little bit better? Or what perspective do you have around that?
Well, I think personally my bias would be yes, but at the same time, you still have state skin in the game, for lack of a better way of describing it, right? And so, their budgets over the past several years have been shaped accordingly. And so, as they've moved more heavily into that Medicaid environment and in a Medicaid expansion state where, many of those services have an enhanced FMAP, the states, their budgeting was basically reestablished with a lower level of state dollars in the mix, right? Nevertheless, going into the economic impact and the crisis that we're in, they're still in a position where they're going to have to reduce state funding somewhere, and that creates the potential problem, that we're seeing. We'll see how it plays out with the maintenance of eligibility or effort requirements. We'll see how it plays out with the enhanced, 6%, 6.5% FMAP that came through the CARES Act. But I think the concern from what I'm hearing is states are still very much concerned about the predicament that they're going in and what that means for overall services.
Great, thank you. Paul, I know that you and Mental Health America have spent time focused on employers and looking at how employers can play a greater role in addressing the mental health and behavioral health needs of their employees. Have you seen any kind of early activities from employers around COVID-19 and addressing mental health needs that you would point to as promising?
Yeah, we have, and I would say, one is certainly the flexibility that so many employers have given to their employees. Many employers never thought about that before, to be able to work remotely and to be able to adjust their schedules in order to manage the time that they have to give to their families. So the flexibility in scheduling is one thing that certainly is out there. Other employers, though, have gone, further and really done a better job of providing authority, to the employees. So, not as much, kind of management oversight, if you will, that's about filing your TPS reports for people who understand that reference, and more in terms of giving people the ability to run projects on their own and to do that remotely. I think others have now really begun to think also, and some have stepped forward to trying to provide a more robust set of service supports, basically, to their employees, recognizing that the old EAP, as narrowly defined, isn't as useful to a lot of people, never has been, for a lot of people, but it's less so at this time. And providing, even kind of remote support groups, virtual support groups among employees that are less formal and more informal, to try to make certain that they are supporting their employees as best they can. And by doing this, a lot of them have started to pay more attention to the stress that people have had, and the fact that they may have thought it was narrowly limited to a small number of employees in the past. They recognize that it's a more universal experience, and as a result, anxiety, depression, frankly, even symptoms of psychosis are more universally felt these times than they have been felt in the past. I think it's made people more sensitive. And we've seen employers, we do recognize with a Bell Seal program that we have, employers that are going above and beyond. And we've seen quite a number of employers now applying for this and earning this seal and doing it based on very concrete things in these areas that they've been doing. In addition to just speaking out, changing the culture and speaking out, having their leaders speak out and say, it's time to say that mental health is important. So and I also like to say that while they haven't been in ours, I've also appreciated certainly my state government, which has done an awful lot in my state. I don't have to mention which one it is, but I'm deeply appreciative that they've continued to pay many employees, who otherwise are not able to continue to do the jobs they were hired to do, but have continued to pay them and not furlough them and move them out to, to the unemployment program, which is now again stressing out an awful lot of people who have come through that. So even though states are going to have to justify some budget shortfalls, and a number of them are really doing right by their employees and setting really good examples for others to follow. One that we've tried to follow in our organization by not furloughing anybody and committing to not doing that for at least a year.
Oh, great. All right, I think we have time for one more question, and I have a question here, I think, that looks like it's targeted towards Beth in really looking at the Medicare program. And so There's been an evolution in the Medicare program around the medical, surgical, and pharmaceutical benefits over the years. But it seems that the mental health benefits have been pretty static. One, is that a fair characterization? And two, what could policymakers do today to speed up the evolution in the mental health space?
Yeah, this is a great point. That's a sort of, the evolution is a nice way of framing it. And I do think it's correct that the mental health benefit evolution, if you will, has lagged behind the evolution around medical and surgical benefits. Though I'll give credit where credit is due. We have seen some progress, like I alluded in my opening remarks, to co-insurance parity for outpatient mental health visits, which was a long time coming, but it did come as of 2014. So, you know, I think that I can reiterate some specific recommendations here in terms of policy changes, but I also think that bigger picture, we need a bit of a paradigm shift where we recognize the importance and the need for mental health services in the Medicare population. I think that at least among some decision makers, there's been a view that, oh, we sort of punt that to Medicaid. Medicaid does mental health. And for dual eligibles who do have high mental health need, okay. But there is also quite high mental health services needs among people who don't have that dual coverage in the Medicare population. Only about 1% of all Medicare spending goes to mental health services, right? It's a teeny tiny proportion that is very disproportionate to the need. The 1 in 4 of all Medicare beneficiaries that have mental illness, or the 60% of those under ages 65. So I think a sort of a values shift is needed here, and then some of those concrete recommendations that cost money, but might get us up to what, like 1.7% of the entire Medicare budget, like inpatient mental health visit parity with general medical visits, covering services delivered by licensed professional counselors, strategies for expanding Medicare Advantage networks, as well as, you know, Medicare is often a leader in delivery and financing innovations like accountable care organizations. And I think that there's some real potential for innovative thinking and testing some innovative models there. In the ACO example, we know that ACOs have done a terrible job incorporating mental health professionals into their networks, and that seems like an obvious sort of low-hanging fruit place to tackle. How do we do a better job of that, where Medicare could play a big role?
Yeah. Well, thank you for that, for answering that final question. I feel like we're just getting started, and there are so many more topics that we could dive into, but we have limited time today. So I want to thank you all for joining us in this important discussion. Just a couple of housekeeping notes I'd like to make. One, for everybody participating, please take time to complete the brief evaluation survey that you'll receive immediately after the broadcast via email. In addition, a recording of this webinar and additional materials on this topic are available on the Alliance's website. Please join me again in thanking Paul, Beth, and Kevin for joining us. That concludes our broadcast for today. Thank you.
Thank you.
Thank you.